This video will cover mechanical ventilators and the medical procedure of mechanical ventilation. Mechanical ventilation assists a patient's breathing using a machine. It is used when a patient cannot breathe on their own or when breathing is insufficient to maintain normal oxygen and carbon dioxide levels. Indications for mechanical ventilation include airway protection, acute respiratory failure, chronic obstructive pulmonary disease, acute lung injury/ARDS, and neuromuscular disorders. Respiratory failure can be categorized as hypoxemic respiratory failure or hypercapnic respiratory failure. This slide highlights hypoxemic respiratory failure. This slide highlights hypercapnic respiratory failure. Types of mechanical ventilation include non-invasive ventilation, such as CPAP and BiPAP, and invasive ventilation, like positive pressure ventilation. Non-invasive ventilation delivers mechanically assisted breaths using tight-fitting masks. It may prevent the need for intubation, but requires optimal patient selection and frequent reevaluation. Patient selection for non-invasive ventilation includes those with rapidly reversible hypoxemic or hypercarbic respiratory failure, acute exacerbations of COPD, and acute cardiogenic pulmonary edema. CPAP is a non-invasive mode that provides continuous pressure to augment oxygenation. Benefits include comfort and simplicity in titration. A limitation is the lack of a set respiratory rate or guaranteed tidal volume. BiPAP is another non-invasive mode with benefits like better tolerance at high pressures, a backup respiratory rate, and improved tidal volume. A limitation is the absence of a set tidal volume or minute ventilation. Invasive mechanical ventilation delivers positive pressure to the lungs via an endotracheal or tracheostomy tube, using a mechanical ventilator to force a mixture of air and oxygen into the airways. Ventilator basics include control or target variables, conditional variables, the trigger that initiates inspiration, and the cycle that determines the end of inspiration. Key physiology terms include airway resistance, lung compliance, atelectasis, which is lung collapse, and derecruitment, the loss of gas exchange surface area. Recruitment is the restoration of gas exchange surface area. Predicted body weight, determined by sex and height, should be used for ventilator settings, not actual body weight. The phases of mechanical breathing include the initiation phase, inspiratory phase, plateau phase for diagnostic assessment, and exhalation, which is a passive process. Important ventilator settings are tidal volume, respiratory rate, fraction of inspired oxygen, positive end expiratory pressure, inspiratory to expiratory ratio, and inspiratory pressure. Assist control, or AC, is a common and safe mode where every breath delivers the same set parameters. It can be volume-targeted or pressure-targeted. Synchronized intermittent mandatory ventilation, or SIMV, also has volume or pressure-controlled settings. Mandatory breaths deliver set parameters, but spontaneous breaths only receive pressure support, or CPAP. Pressure-regulated volume control, or PRVC, is an assist control type that provides the desired tidal volume at the lowest possible pressure. The pressure target adjusts based on lung compliance. Pressure support ventilation is a partial support mode where the patient receives constant PEEP plus supplemental pressure when triggered. The patient determines the peak inspiratory flow, rate, and tidal volume. This slide outlines guidelines for initial ventilator settings in different clinical scenarios. Potential complications of mechanical ventilation include barotrauma, volutrauma, ventilator-associated pneumonia, and hemodynamic instability. Weaning from mechanical ventilation involves spontaneous breathing trials, T-piece trials, and extubation criteria. This slide displays a weaning algorithm for mechanical ventilation. This slide is blank. When weaning efforts fail, consider issues like the endotracheal tube size, arterial blood gases, and ensuring adequate nutritional support. Continued considerations for weaning failure include regularly clearing secretions, avoiding neuromuscular depressing drugs, using bronchodilators for airway obstruction, and preventing oversedation. This slide shows a management algorithm for high peak airway pressures. Potential causes for a low exhaled tidal volume or low minute ventilation alarm include leaks in the circuit, patient issues, or worsening respiratory system compliance. This is the final slide of the video.